अभी अभी इनको शो हो रही है, ग्रीन में ऐड पे करेंगे ना तो ऑफ हो जाएगा, ग्रीन में तो ऑन है। लाइट शो को देखने कैसे करें, लाइट शो ऑप्शन, अभी मेरी स्लाइड्स दिख रही है?
It's visible. We can
It's
see.
visible, no?
Yeah.
Yes, we can see, ma'am, your slide. Now we are YouTube live. Madam, you can stop sharing. We can see your slides.
We shall wait for 5 more minutes.
What is the delay, dear? 4 o'clock. क्या स्लाइड्स में कुछ है? आज हमारा टेक्निकल पर्सन नहीं है।
मैं चालू खोल के रखूं स्लाइड्स? नो मैम। Anuradha, after 3 minutes, we will start the session. Okay? I'm just now starting the slide. One slide up. Anuradha, once you will start, tell me, then I will start that. I will keep that flyer.
वो बंद कर देना।
Good afternoon, Madhu madam.
Hello,
Hima,
Seema ma'am.
who else? All are joining. Good
It's
afternoon.
also been criticized as being paternalistic.
Namaskar, madam.
Yes, it focuses only on the patient, but sometimes the focus ends up completely on the clinician, and the clinician will impose their own values. It ignores the patient's relational impact on the family. That we have talked about a different way of looking at autonomy.
Request everyone to mute, please.
How one's own position of the family or the society that you are in contributes to one's feeling of autonomy.
I think more than 20 people have joined. We can start.
Yes, we can start the session.
Hello. World Thalassemia Day, led by Thalassemia International Federation, TIF, is observed every year on 8th May to raise global awareness about thalassemia, which is a rare blood disorder, genetic blood disorder, to support the parents and their families and advocate for better accessible treatment and preventive strategies. Good afternoon, all the vibrant ladies in this WPF Zoom platform in today's webinar on context of World Thalassemia Day. As we all know, theme of this year's World Thalassemia Day was Hidden No More, Finding the Undiagnosed, Supporting the Unseen. Keeping this in mind, we have planned today's webinar, which is our 6th academic activity of the current year 2026, which focus on early detection, comprehensive care of individuals with blood disorder. This campaign shines a light on individuals living without diagnosis and needing better care. With this briefing, Now I invite our chairperson, Dr. Madhu ma'am, for her welcome address. Over to you, Madhu ma'am.
Good afternoon. Good afternoon, all beautiful people around there. And I'm not seeing any seniors, but if any senior is there, my respect to them. I welcome you all on behalf of Team WPF today and this afternoon to discuss to improve the life of thalassemic children. And you all know the burden of thalassemia is quite a lot on our country. Every year, almost 10 to 15,000 children are born with thalassemia major, and almost 1.5 lakh children are still suffering. And the parents spend quite a lot of money, almost 2 lakh rupees per annum, to take care of these children. So three beautiful ladies, Dr. Preeti, Dr. Liza, and Dr. Bhakti, are going to update us about how to improve the care of these children so that they can live a better life. And definitely, we all know these children, screening is for these parents, screening is available. And I believe prevention is always better. So we should focus on that. But still, the treatment has also become better with the bone marrow transplants, though it is a bit costly. So let us listen their viewpoint, how we can improve the quality of life of such children. Over to Anuradha
Thank you so much,
for
ma'am.
further. Yes.
I also want to take blessings and a few lines from our ex-chairperson, Dr. Sangeeta Lodha ma'am.
Yes, thank you, Dr. Anuradha. Actually, this is my privilege to just present this thalassemia topic today on behalf of World Thalassemia Day, which is celebrated all over the world on 8th of May. But as during those period, all over the world, so many programs were going on. So I just keep this webinar after 1 week. And I think today many patients, my personal patients who are now adult, will join this webinar, and it will be a definitely fruitful webinar and a guiding force for all my thalassemic angels who will join today. Thank you.
Thank you, ma'am. So the topic of today's webinar is navigating thalassemia in adolescents, strategic, safe, and sustainable from transfusion to transformation. To conduct this webinar, we are having three brilliant speakers. Dr. Preeti S. Mehta ma'am, Dr. Bhakti Kataria, and Dr. Lisa Pulsara. We'll have their lectures one by one. First of all, let me introduce our brilliant speakers. Dr. Preeti S. Mehta ma'am is pediatric hemato-oncologist and bone marrow transplant physician. She has done her fellowship from UK in bone marrow transplant. She is senior consultant at SRCC Children's Hospital, and she's been section editor at IGC, reputed journal, reviewer in EHO journal. She's a very renowned pediatric hemato-oncologist and bone marrow transplant physician. So her topic will be beyond transfusions, nutrition and quality of life, food, fitness, and future for our cute adolescents having thalassemia major. Over to you, Preeti ma'am.
Thank you very much for this kind introduction. And I want to thank the Women Pediatric Forum team and Madhu Madam and Sangeeta Madam for giving me this opportunity. So we always talk about medications, blood transfusions, chelations in thalassemics, but the other aspect of what we can take care of is nutrition, and we need to, as clinicians, help them in improving their quality of life as well. Am I audible, right? Hello?
Yes, ma'am, you are audible.
Right. So, and my slides are visible, right?
Yeah.
Okay, so without wasting time, thank you for the kind introduction. And I am a senior consultant at NHSRCC Children's Hospital, Mumbai. So now what I want to say is that undernutrition is definitely prevalent in our countries, and more so in thalassemics, where the nutritional aspects, it ranges anywhere from 5% to 70%. And this causes not only It is associated with growth failure, delayed pubertal development, the immune function gets affected, the insulin secretion is altered, and the lipid profile also gets altered. So growth and nutrition, apart from regular blood transfusion and chelation, is a very important aspect in the lives of these children who are undergoing chronic illnesses. So when we talk of the energy and the caloric intake, we have to not only concentrate on their caloric intake, but also ensure that there is no micronutrient deficiency in these children. And when we increase the caloric intake, it significantly increases the insulin growth factor 1, the skin fold thickness, the mid-arm circumference, and the body mass index. And this helps in the children growing better. But this relationship between the intake and the need, it should be closely followed even after the growth period is over, because we don't want them to become overweight and obese individuals. Because apart from this regular blood transfusions that they require, they have no other abnormalities. So if they are well taken care of as far as blood transfusion, chelation, and the nutrition are concerned, they can be very, very productive in the community when they grow up. So now when we talk of the vitamins and minerals, these deficiencies in thalassemia children lead to poor growth, bone health, and altered glucose homeostasis. So when they come as clinicians, when a thalassemia child comes to our clinic, what we need to be careful about is prescribing the required minerals to them as a regular part of their treatment, out of which zinc is a very, very important mineral. And we know it's indispensable for hundreds of enzymes and metalloproteins in our body. And if there is a zinc deficiency, it manifests as growth failure and increased susceptibility to infections in children. And you know that they are already on either desferrexamine or deferrixirox, and which already puts them to a greater susceptibility to infections. And in can present.
Somebody has requested to increase your volume and a bit slow, because many patients who are unable to understand English, so they can't just catch the fast English. Okay.
Okay.
Please.
So in adults, the deficiency leads to hypogonadism, diabetes, and poor bone mineralization. And so all these complications are already known in thalassemia children. So you can understand how important zinc is in these children, not only in childhood, but even in adolescents and adults. And why does this zinc deficiency happen in thalassemics? It is because the intake is deficient, or the excretion in the urine is more. There may be an iron overload in these children. The oral, because they are on oral chelators, which again contributes to deprivation of zinc and the reduced zinc binding capacity. Now, a lot of thalassemic children have already developed diabetes, and because of that, and because of the cardiac this, they may also be on thiazide diuretics. And so because of the diabetes, the thiazide diuretics, again, their zinc is lost. And because of this, the children who are definitely on having a cardiac involvement and are on diuretics require frequent zinc monitoring and zinc supplementation. But you know, the TIF, Thalassemia International Federation guidelines ask not to give it routinely to all patients, but to those who have a zinc deficiency, a poor growth, or a reduced bone mass, or are at risk of diabetes. And I feel this is TIF, which has a different environment and a different country. But in our country, I think we should be supplementing zinc to all the children that who come to us, 25 milligram per day, up to a maximum of 40 milligram per day. And monitoring of the zinc level should be 6 monthly. And when we monitor the zinc level from the plasma or the serum, you have to draw it fasting and at least 24 hours after the last chelation dose is given. Now, second is iron. We know that iron is contraindicated in children with thalassemia and non-transfusion dependent thalassemia. So if they are, what happens is, just like in non-transfusion dependent thalassemics, if the thalassemic children are not transfused well, then their intestinal iron absorption increases tremendously, and it increases up to 5-fold. And we don't want that to happen. So in this group, we need to restrict that dietary iron. If the child is very, very well chelated, very, very well transfused, with the hemoglobins kept in a very good condition, still we don't want them to be prescribed iron. Even if they are pregnant, they don't need these iron supplements like the normal women. And black tea, drinking black tea after meals, it helps in reducing the absorption of the non-heme iron. So this should be advocated to these children. Okay, those who are non-vegetarian and who are not on regular chelation, they should also limit their consumption of beef, liver, pork, lamb, and chicken. Now, calcium, we know that calcium is vitamin D is very, very important for the bone health of these children. And the normal levels of vitamin D are anywhere up to between 30 to 15 nanogram per level. And if the levels are less than 10 or less than 25, it is considered as a deficiency. And between 20 and 30, it is considered as insufficiency. And what does vitamin D do? It causes poor bone mineralization. So you get thalassemic bone disease. The bones are brittle. They can easily get fractures. It causes muscle weakness. The heart muscle gets weakened, because of which the left ventricle dysfunction is there, and the iron uptake is more in these children. Now, calcium goes hand in hand with vitamin D. And this calcium may be low because either it is low in the diet or there is a decreased calcium absorption. And this, along with vitamin D, it contributes to the calcium homeostasis. And if the patient has hypoparathyroidism, then the person may have hypocalcemia. And secondly, when they receive these drugs like deferrirox, then that also causes renal tubular dysfunction, because of which they lose calcium in the urine, and it can cause nephrocalcinosis, that is stones in the urine. Now, this along with deferoxamine also, it was thought that it gives rise to calcium stones and nephrocalcinosis, but that has not been linked as such. So calcium is prescribed if you think that the child has low calcium levels because of decreased dietary intake. And vitamin D supplementation should be given if they are deficient, and you should not give it over a long term. If they are deficient, you give a short-term dose supplementation, and then you give them a daily maintenance of 1,000 to 2,000 units, and you monitor their vitamin D levels every 6 months. So you should, after the age of, when they are in the pubertal age, you should, or after the age of 10 years, you should monitor their serum calcium levels, correct it for the albumin level, and also do the urinary calcium to see whether they are maintaining good calcium levels. And what you advocate is food rich in calcium, like milk, yogurt, tofu, kale. And if you think that the child is having hypoparathyroidism or the dietary calcium intake is not good, then you can give supplemental calcium to these children. And you can monitor if they are on diuretics or anything, then you can monitor the calcium levels a little more frequently. Now, we all know that folate is an essential vitamin crucial for the synthesis of nucleoproteins, and it is lost because of the ineffective erythropoiesis that happens in thalassemias. There is a folate deficiency. But if they are very well transfused, then the endogenous erythropoiesis is not happening, and then they will not develop folate deficiency. But in our countries, we see most of them are on low transfusion regimens. The transfusions they receive is usually when the hemoglobin has dropped to 6, 6.5, 7, or 8. And that's why folate supplementation is very, very important in these children. So what does folate do? It also prevents the thrombotic risk and the atherosclerotic risk in the adult population, in the children who are in the teenage group and beyond. So folate works for these children. So folate is important in this group of children. So you can give folic acid supplementation up to 1 milligram per day or 5 milligram per week. And it must be considered, especially in children who are on low pre-transfusion hemoglobin levels, because it helps also in decreasing the risk of thrombosis. I hope I've made myself clear till now that zinc is very important for these children. Folate is also equally important. Vitamin D levels need to be monitored and supplemented, and calcium, if they are low, then they need to be given calcium supplements. Preferably give calcium-rich foods, otherwise give the calcium supplements. Next is vitamin E. It is frequently depleted in thalassemia patients, and that is because of the high levels of oxidative stress, hepatic iron overload, and associated liver damage. Although reduced dietary intake has also been demonstrated. And the supplements of vitamin E have shown to reduce the oxidative stress in both NTDT and TDT patients. And it also reduces the lipid peroxidation. So you don't need to give the capsules or anything. You just need to give a food which is rich in vitamin E, like eggs, vegetable oil, nuts, or seeds. And if you think that the diet is still not adequate because the teenagers like to eat what they want to eat and they don't listen to what the parents want to give them, So if you think that the vitamin E is deficient, then maybe you can do a supplementation for 3 months, short supplementation, because if you prolong it, then it increases the risk of bleeding and the intracranial hemorrhage. Now, vitamin C is an antioxidant. It is integrally involved in iron metabolism, and it is depleted in conditions where there are free iron radicals. And you know, thalassemia is a condition with free iron radicals. So the oxidative stress induced by the iron overload causes vitamin C deficiency in these children. So if you have vitamin C deficiency confirmed, then you supplement in conjunction with the chelator that you're giving. If you're giving deferoxamine or you're giving deferrizirox and you have an underlying vitamin deficiency, then you can supplement with vitamin C at 2 to 3 mg per kg per day, typically 100 milligram per day, especially in heavily iron overloaded patients, especially with the chelation therapy, not otherwise. So what I want to draw your attention to is that routine supplementation without identification of single nutrient deficiency is not recommended. So folate, vitamin D, and zinc can be given to these children. The rest, you will have to say that there is nutritional deficiency, and then that's where you supplement these children. These are the TIF guidelines where I am talking from. And a daily multivitamin mineral supplement without iron is suggested. And supplementation should not be a precedence. A healthy, well-balanced, nutrient-dense diet and adequate iron chelation should be the prerequisite, and the supplementation comes later. But yes, folate, vitamin D, zinc should become a part of your prescription always. The rest of it, vitamin E, vitamin C, calcium, you should see if the patient requires or not. So these are the vitamin and mineral supplements that you need to give the thalassemia children. Apart from that, a diet rich in antioxidants, that is fruits and vegetables, should be recommended for all patients. Now, what is so important about botanicals like tea? Tea, it contains polyphenols like tannic acid and tannins, and these inhibit the absorption of non-heme iron. And so tea, coffee, cocoa, red wine, and some herb teas have a high concentration of this tannin and tannic acid. And a simple cup of black tea can reduce the iron absorption by 40 to 90% if taken after meals. And a cup of coffee can decrease it by 39%. So you can, in your prescription, you should always tell the parents that after the meals, you should try to give these children black tea. And adolescents, basically, I think it's the fad. The black tea and black coffee is the fad these days. So I think they would go with it and should not be a problem. It really helps the children. Secondly, a consumption of green tea, 3 cups a day after meals for a year, in addition to chelation therapy in NTDT, has shown to decrease the liver iron concentration compared to chemotherapy, chelation therapy alone. Now, what are these green tea extracts? They are rich in polyphenolic compounds and they have iron chelating properties. But the problem is that they are very hepatotoxic. So where they are available in the US, they have this criteria written on it that if you have a liver injury, you should be careful and you should not take it on empty stomach. But they have been effective in improving the ineffective erythropoiesis, the and the oxidative stress.
Hello, please keep yourself on mute mode.
In iron overloaded beta thal mice. So tea consumption, either black or green, to inhibit the iron absorption may primarily be of benefit if taken with meals for patients with NTDT, and applies to children with thalassemia also, TDT, and green tea extract should be used with caution. The last is the L-carnitine. Carnitine is a butyrate derivative with potential benefits in beta thalassemia because it is believed to have the 50 mg per kg per day given to a small group of patients for 3 to 6 months had improved the heart function and the exercise performance, improved their pulmonary artery systolic pressures in those who had pulmonary hypertension. It increased the transfusion intervals, reduced the bone pain and the muscle weakness. So prescribing L-carnitine may be beneficial at 50 mg per kg per day, although exercise should be cautioned in patients with thyroid dysfunction. So basically in children with thyroid dysfunction, So usually beyond 10 years of age, monitoring of the thyroid profile, and then required, you can give L-carnitine. And as I said, it improves the heart function, the exercise, increases the transfusion intervals, reduces the bone pain and the muscle weakness. We have heard a lot, we know that people sometimes take wheatgrass. Now, wheatgrass definitely has health benefits. It contains chlorophyll, vitamins, minerals, and several enzymes. It is a juice that is prepared from the leaf buds of the wheatgrass plant, and it has the ability to lower the cholesterol, regulate the blood sugar, aid in digestion, decrease inflammation. However, there is insufficient or from curcumin for that matter. But definitely it doesn't say that it has negative effects. So those who are taking or who are happy taking it should continue doing so, because it is not going to harm. If at all, it is going to help. So the key points that we have analyzed till now is that routine and strict biochemical and clinical assessments are required to clarify nutritional status in children with thalassemia, and factors such as caloric intake and micronutrient deficiency should be considered in instances of poor growth. And a dietitian is very, very important when we are looking at these children. Now, when we monitor the chart in adolescents, anthropometry, it's very important, and it needs to be done every 6 months until pubertal maturity, with calculation of the body mass index and the growth velocity, and should be charted on the centile charts. A Tanner staging for the pubertal assessment needs to be done every 6 months. Urinary and serum calcium, at least annually from 10 years of age. Thyroid profile from 9 years of age. 25-hydroxy vitamin D levels every 6 months, and try to maintain the levels above 30 nanograms per ml. The minerals, copper, magnesium, zinc, etc., annually from 10 years or earlier if specific nutritional deficiency is suspected. The glucose and insulin or the oral glucose tolerance test from 10 to 18 years of age every 2 yearly, and then annually thereafter. And the DEXA scan every 1 to 2 years starting from 10 years of age. So I've finished the nutritional component in these children, which should come automatically when we see a thalassemia child. As to we know that we need to prescribe the zinc for them, the folate for them, the vitamin D for them, calcium if required, and the rest if there is a deficiency accordingly. Now, nutrition is one aspect and lifestyle is another aspect. A healthy lifestyle includes all activities that encourage physical, spiritual, and mental functions and contribute to decreasing the health problems, managing the stressful events, and improving the quality of life. Life activities that can be influenced by a healthy lifestyle include physical activity and exercise, self-care and management along with self-efficacy, social integration, which includes education, employment, relationships, that is marriage, reproduction, dietary habits, and optimal nutrition, and daily habits such as alcohol intake, smoking, and substance abuse. So, when you meet an adolescent thalassemic, the questions that are there on their mind is that I need to come to the hospital frequently for blood transfusions. It's hampering my education, my work. Can you adjust the timings? Can I come in the evening after my work hours? Can I come in the evening after my school hours? And what jobs can I accept? Will there be an employer prejudice? Will I have absences? These are the things that are running in their mind as far as work and education is concerned. If they are in the marriage age group, can I get married? Can I have children? How long will I live? Will I live long enough to see my children grow? Can I have life insurance, health insurance? Will I be able to get a mortgage? So you can understand the anxiety that is brewing in their minds. So it is not just blood transfusion and chelation. Life is much more for them apart from this. And you can see the anxiety that the questions are showing in this. And why not? Because they are entitled to a life similar to any normal human being. When it comes to sports, activity, dancing, what is optimal? How much is too much? How much can I do? What about travel? Where can I get blood? Yes, I would like to go on a holiday spree abroad. I would want to go for 2 weeks. I would want to go for a month. Where do I get my blood in case of emergency? Can I travel with medication? What is safe? What about smoking and alcohol? What is allowed? And then it's my health issues. Will they get worse? Will they be good enough that I don't have complications? Can the hospital provide enough blood for my transfusions? Will the healthcare system be supportive rather than obstructive? So, holistic approach to patient care includes recognition for the need for social integration and a normal life. The treating physician should be able to provide advice on lifestyle issues as well. Physical activity you should encourage, but you should look at each child's profile, whether the child has any comorbidities, how much is allowed, and do an ergometry and say, yes, this is what you can have as far as physical activity is concerned. You should try to incorporate their demands and see that the clinic, the transfusion times are kept flexible, and you take into consideration their work commitments and their educational commitments. So availability of some evening and weekend clinics, transfusion sessions in the you also need to liaise with the teachers, the employers, to help them understand what this condition is and how it can be managed and how can they cooperate with the particular patient so that the life is more peaceful for the child or for the adult. Now, substance abuse, consumption of tobacco and substance abuse should be avoided. It should be avoided for everyone. And so they are no exception. But for them, alcohol can potentiate the oxidative damage of iron. And it can aggravate the effect of the hepatitis viruses on the liver tissue. It also affects the bone formation. And there is a higher risk for osteoporosis. So alcohol, as far as possible, they should avoid to have alcohol if possible. And a quality, and how to be this lifestyle, there are quality of life assessment forms. So there are two types. One is the generic forms, and the second one is the thalassemia specific forms. These you will get on the internet also. So if you want to assess their quality of life, there are different types of forms, which is known as, one is developed by the WHO, which is known as quality of life assessment form. The second one is a 36-item short form survey, and they measure the health policy evaluations, a general population survey, and it has been extensively used in the US for thalassemia research, including observational studies and clinical trials. There is also a pediatric quality of life inventory, a patient-reported outcome measurement information system, and a Dartmouth primary care cooperative information chart. Now, these are the general forms which are used also for the thalasssemic children. But there are disease-specific tools also, and these forms basically assess their quality of life. So there are multiple questions where they are asked about the different aspects of their life, and it is judged from that what quality of life are they living. And so for thalassemics, there is a transfusion-dependent quality of life questionnaire, a specific thalassemia quality of life instrument questionnaire, a thalassemia adult life index, and a non-transfusion dependent thalassemia PRO. And that is used to measure the tiredness, the weakness, and the shortness of breath in these children. So according to the WHO definition, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And well-being has been defined as a combination of feeling good and functioning well, the experience of positive emotions, as well as development of one's potential, having some control over one's life, having a sense of purpose, and experiencing positive relations. So the healthcare professionals should, beyond following clinical protocols, have the clear aim of reducing as far as possible the degree to which this disease interferes with personal and social lives. What they need from us is not society. I just want to end with this child, a 17-year-old thalassemia major child, whose father was a complete match. Now, it so happened that till 16 years, they were not aware that the donor is in their own house, the father being a complete match for them. It was in one of the free HLA camps that they realized that the father is a complete match, the father is a rickshaw driver, and they came to me for transplant. The girl sailed through the transplant easily at 17 years of age, but post-transplant, she had recurrent pericardial effusions some 3-4 times in the first 6 months post-transplant. But after that, she settled down beautifully. And when she was coming to my OPD visits, I used to ask her, that, what do you think? You think you have done a good thing by transplanting yourself? You're having to admit again and again 3 to 4 times. She said, Madam, I don't have to come once a month every day for this blood transfusions. I don't have to take the medicines every day. my life has really changed and I'm very happy. So in spite of the little complications that she faced in the first 6 months post-transplant, the outlook towards life had completely changed. And now she is more than 1.5 years post-transplant. She has started attending college and she lives a very healthy, normal life. Thank you.
Yeah.
Thank you very much. Open to questions.
Thank you, Dr. Preeti. Now I request Dr. Liza Bulsara, madam, to present her talk. It was really a very informative session, Dr. Preeti. I think we need a complete session of 1 hour from you for about this nutrition. Thanks for this nice presentation and elaborative discussion about the topic of nutrition. And now Dr. Liza Bulsara, her topic is Transforming Thalassemia Care, the Dawn of Curative Therapy in Thalassemia. Dr. Liza Bulsara is very much active in all the social platforms. She is a very excellent pediatric bone marrow transplant surgeon, and I think everybody in this forum know her, Dr. Liza. So over to you, Dr. Liza, for your presentation.
Thank you, madam. Thank you so much for that introduction. I think you have been mentoring us from a very long time.
Yes.
Am I
yes.
audible?
Yes, ma'am.
My screen is visible.
Yes.
My slides are visible, madam?
Yeah.
Okay. So today we are talking about thalassemia.
Yeah, ma'am, your video is off.
Please keep yourself on mute mode. Accept speaker, please.
Okay.
Yeah. Go ahead.
So I carry on with the presentation. I'm Dr. Liza Balsar. I'm a pediatric hemato-oncologist and a BMT physician. And I thank WPF for this platform today for very important topic, because we talk about everything else except thalassemia in adolescent life, because they cannot be transplanted because of many features. There are new therapies coming which cannot be implied on them. So today we are going to talk about what is the future. So we all know it is a production defect, it is generational, hereditary. Ideal care, very unfortunately, we are able to give less than 15% of thalassemia. A complete TIF guidelines, a very few people get it. We are only able to transplant 3% of whatever thalassemic existing patients we have. Only 3% we are able to transplant till date. So every year on World Thalassemia Day, we have a poster competition where the thalassemia major makes one drawing, and we have this all over India. And one guy from Ulhasnagar, his name is Nitesh, he's a thalassemia major, had made this painting, and definitely he won the first prize. But look at the painting. The child is there, there is a pump, there is one blood transfusion. India is a thalassemia capital of the world. There is a blood shortage. Their parents have been told कि इन पे पैसा क्यों खर्च करना है, ये तो 10-12 साल में मर जाएंगे और इनको पढ़ाना भी क्यों है. This is the age and dawn we had come from. Now we have included transplant. And if we go back to the TIF guidelines for any optimal transplant transfusion care, these are the number of tests they will have to do: monthly, 3 monthly, 6 monthly, 12 monthly, and then if need be, whenever possible, as per their clinical guidance. ये मैं भी नहीं कर सकती, ये आप भी नहीं कर सकते. It is not possible. My insurance also will not cover all this. Imagine going day after day, night after night, going through this throughout the life. So there is one beautiful article of 2023 by National Medical Journal to do. They had calculated the cost. Now see it, the direct cost and indirect cost and one intangible cost. So this is what the cost a parent bears when a thalassemia child is born and goes to the adult life. And last two column, loss of wages when the parent comes for transfusion days and loss of school days. And all this also doesn't include the intangible cost we are talking about. So these are my adult thalassemic. Now I will go right to left to introduce them. This photo has been taken with their consent here. So the first one with the specs guy is a vlogger. He is a YouTube vlogger. He has a channel. Next to him, there is one girl. She is a social worker working in thalassemia. The guy behind her is a graphic designer. There is a IT worker. The girl sitting is a German teacher. And the guy in the spec is a stockbroker. And the guy in the helmet who did not want to reveal his face is a national level judo player. Their parents were told that ये 10-12 साल से ज्यादा जिंदा नहीं रहने वाले. So what for them? Because they do not have a match, they cannot be transplanted, they are all in their 30s, and they are looking at the door for a future which is there. There is some light at the end of the tunnel. So what we have currently is targeted biologics, metabolic modulation, precision chelation, and curative option potential like CRISP and gene therapy. I will not go into the nitty-gritty of this. I will want to be very, very crisp about it. This is the flow chart. I think maximum of us are pediatricians who have joined, and I think 10% patients. लेकिन patients भी इतने महान हो चुके हैं कि they are also hematologists because they know more than me probably because they've studied the disease like that. So beta thalassemia disease, we all know a pure point mutation happens. In this point mutation, there is a BMT option, hydroxyurea if it is a delayed if the thalassemia symptoms come at when intermediate type of 6-7 years, gene therapy and gene editing will be taking care of the point mutation. Now there are certain drugs will be taking care of ineffective erythropoiesis, which is ruxolitinib, luspatercept, and inhibitors. Anemia hemolysis will be taken care by blood transfusion and splenectomy. We do not do splenectomy. We do not prefer to do splenectomy until unless we are pressed against the wall. And iron dysregulation, we take it care by iron chelation till now, but the new modality is minihapsidin and the inhibitors. Why we want to do it? Because we want to stop the secondary clinical manifestation which are happening in our adult thalassemia. So how will this work? So luspatercept आप सबने सुना है, the vial is expensive, there are side effects of it, but the results are good. Ruxolitinib is available, we are not, the trial is still in phase 2. Drug targeting iron metabolism is currently what I am looking for, the minihapsidins, the ferroportin inhibitors and apotransferin, because we are not able to manage ion chelation. थोड़ी गलती हमारी साइड से, बहुत सारी गलती उनकी साइड से. So this is what is happening.
Hi. हेलो आप लोगों की हो गई 1 घंटे की मीटिंग 4 बजे स्टार्ट होके.
Neelam ma'am, please keep yourself on mute mode. Just a minute. Lisa ma'am, just a minute.
Yes,
please.
yes.
Hi,
yes.
Dr. Neelam Mohan madam. Thank you very much for joining us, Dr. Neelam Mohan madam, President Central IP. And we are just taking a webinar on thalassemia. Yeah, most welcome, madam. Dr. Lisa.
Thank you so much. Apologies.
Good evening. Yes,
Dr.
dear.
Lisa, you can continue.
Yes. So luspatercept is currently available in trial form in India also. A lot of our patients have taken this trial. The BELIEVE trial, the first phase trial, has shown 33% of the result. Basically, it increases the percentage of mature RBCs. तो blood इतना जल्दी टूटता नहीं है. इस वजह से the anemia, the gap between two transfusion is increased. So currently, we are very, very hopeful because it's a very expensive drug. We want it to help us in a further forum also. So this is the phase 3 trial outcome. 336 patients more than 18 years were enrolled. 33% of reduction in the transfusion burden, which became 1 month of transfusion. Some patients have also achieved free transfusion for 6 months with luspatercept. So it is once in 21 days subcute injection, and we can take it for 6 months for the trial version. For ruxolitinib, we are already using in chronic GVHD post-transplant, but there are currently approved for polycythemia vera, myelofibrosis. Now we are looking it for thalassemia also. The TRUTH trial gives us a very good study model where we have to take this blood injection 4 weeks apart, and the transfusion has increased up to 6 weeks. Now, we all came to know regarding this 3 months back that this drug has suddenly become approved for anti-DT patient, non-transfusion patient, for the control of hepcidin for the reduction in iron in liver. For the anti-DT patient, it was already there in the PK deficiency. Now we are taking it for the transfusion dependent patient also. So, So we all know, because we are working with iron deficiency anemia also, that hepcidin is a key molecule regulating the iron metabolism. Currently, the iron deficiency guidelines are also changing because of hepcidin, because it opens the port every 24 hours. So it is said that you take iron 24 hours alternate days. So this is the key relation where mini hepcidins will come in, which will be controlling the hepatocytes where this regulations are there. So it will decrease the iron overload. These are the iron modulators, 3 type of it. I am not going into detail. And these are the future targets where we want the macrophage manipulation, and we also want to re-engineer the whole ferritin and non-transferrin bound iron. That's why iron chelation रोज लेना बहुत जरूरी है, because once the NTBI becomes iron labile, अगर वो एक बार हेपेटोसाइट में बैठ गया तो चेलेशन उसको नहीं निकाल सकता. इसीलिए हम हमारे पेशेंट्स को हमेशा बोलते हैं, घर में शादी है, कोई भी फंक्शन हो, आप अपना आयन चेलेशन मिस मत कीजिए. So these are the trials which are already there for beta thalassemia patient. One luspatercept which we have completed in detail, and it has increased iron hemoglobin concentration and also decreased the transfusion requirement and increased the gap of transfusion. Belief trial has happened, beyond trial has happened in both of them. Ruxolitinib truth trial has happened, and bone marrow transplant, we all are doing it. We have very good results if they are properly managed. अगर liver spleen ठीक है, ferritin 2000 से कम है, transfusion बहुत कम लगे है, उस scenario में it goes very smooth. Beyond that, allogenic transplant में हम अभी मैच सिबलिंग डोनर 12/12 मैच से बहुत कंफर्टेबल है. हैप्लो में the cost is above the roof. हमें बहुत ज्यादा मेहनत करनी पड़ती है, and side effects are also there. Mud transplant, again the cost is issue, but this is all we have tried up to 15 or 17 years of it. Beyond that, because ferritin, iron overload, transfusion load इतना हो जाता है कि हम उस पे transplant नहीं कर पाएंगे, and we do not prefer. Gene therapy हम 20 साल से बात कर रहे हैं. It is just at the door. Currently, CRISPR has been approved for 12 years and older children. It reactivates the fetal hemoglobin, and we have been able to achieve transfusion independence in 90+% in clinical trial participant. We are yet to do CRISPR in our setting. So, अगर मुझे किसी ने पूछा कि अगर जीन थेरेपी आता है तो मैं ये लूं या फिर मैं उसको छोड़ दूं, because the cost is from 16 crore if it is outside India. Indian made CRISPR can be to 30 lakhs, लेकिन somebody is paying the price. So there is a beautiful study which has happened in 2025 where they have done the versus gene therapy versus 40 years of transfusion. And please look, the framework they have taken in consideration is cost effectiveness, quality of life years. There is no way हम लोग ये compare कर पाएंगे, क्योंकि the quality adjusted life years after the person is transfusion independent cannot be matched with any other thing. So we need to be prepared for this big challenge, जहाँ पे हम इंडिया में हम लोअर सोशो इकोनॉमिक क्लास को कैसे ये सारी चीजों को अवेलेबल कराए. बट इफ यू आर अ पेरेंट और अ पेशेंट हु इज लिसनिंग टू दिस ब्यूटीफुल वेबिनार, आई हैव ओनली वन रिक्वेस्ट. आप ट्रांसप्लांट एलिजिबल हो, आप नहीं हो, आप फ्यूचर को देख रहे हो, देयर इज ओनली वन होमवर्क यू नीड टू डू. आप प्लीज प्री ट्रांसफ्यूजन हेमोग्लोबिन 9.5 to 10.5 ग्राम पे रखिए. प्री ट्रांसफ्यूजन ब्लड चढ़ाने से पहले आपका ऑप्टिमल चेलेशन होना चाहिए. आपका फेरिटिन 1000 से 2000 के बीच में होना चाहिए. एंड देयर इज नो ऑप्शन फॉर कॉम्प्रिहेंसिव केयर. यू विल हैव टू डू इट, क्योंकि कल चल के डॉक्टर प्रीति, डॉक्टर संगीता, मैं, डॉक्टर नीता मोहन अगर कल चल के कोई भी ट्रायल लाए तो मैं चाहती हूं कि हमारे सारे बच्चे उस ट्रायल के लिए एलिजिबल रहे. और ये तभी हो पाएगा अगर हमारा प्री ट्रांसफ्यूजन हेमोग्लोबिन, हमारा चेलेशन और कॉम्प्रिहेंसिव केयर इंटैक्ट रहेगा. With this, I end my talk. Thank you so much.
Thank you, Dr. Lisa, ma'am.
And Dr. Lisa, I just want to say only one thing. In 1990, I have given a talk on thalassemia. 36 years back, and that time I was talking about कि एक दिन आएगा जब जीन थेरेपी आएगी और ये बोन मैरो ट्रांसप्लांटेशन या आयरन चिलेशन सबको पीछे छोड़ देगा. And now the time has come. So I think
Yes.
I'm just attached to thalassemia since last 38 years almost.
Wow.
Yeah. Over to Dr. Anuradha for the proceedings.
Thank you, Dr. Lisa, ma'am. Our next speaker is Dr.
Dr. Anuradha, just Dr. Neelam Mohan, madam,
Pediatric
are you there?
endocrinologist. She is in Nasik, done her fellowship from BJ Wadia Hospital, Mumbai. She's been faculty in various national and international conferences. She's having special interest in pediatric diabetes management. Her topic of talk is endocrine window in thalassemia care. Over to you, Dr. Bhakti.
Yeah, just Dr. Anuradha. Neelam ma'am, are you there? Neelam ma'am, our Central IP President, Dr. Neelam Mohan madam, has just joined. I think she has left. Okay, we will continue with Dr. Bhakti Kataria, and then if suppose she join, we will definitely take message from her.
Yeah.
Over to you,
Thank you
Dr.
so
Bhakti.
much, ma'am, for the kind introduction. A very good evening to all the fantastic doctors who have joined with us, along with our warrior parents of all the thalassemia parents. So our today's talk is the endocrine window in thalassemia care. So why does this really matter? Thalassemia is a blood disorder, right? But why are we talking so much about hormone, endocrine glands? Because of all the patients who has thalassemia, 50 to 90% of them develop at least one endocrine complication. And hence, endocrine screening is no longer optional. It is must for the better quality care. So, because of repeated blood transfusion, we all know that there is progressive iron overload. Iron deposits into the endocrine glands and we get endocrine dysfunction. Of course, there are some other contributors like thalassemia itself, chronic anemia and hypoxia, nutritional deficiencies, as Preeti ma'am said, zinc deficiency, folate deficiency, calcium, vitamin D, magnesium, selenium deficiency, all of them can cause endocrine dysfunction. Intensive chelation, especially desferoxamine-induced chelator toxicity, can also lead to endocrine dysfunction. Associated comorbidities. Now, we all know that transfusion-related infections like hepatitis B and hepatitis C can also affect the endocrine glands. And last but not the least, the oxidative stress. So all of these can lead to endocrine dysfunction. So these are all the glands which are affected due to iron overload: pituitary, thyroid, testes, ovaries, pancreas, parathyroid, adrenals, bones. Every single gland gets affected because of iron overload in patients with thalassemia. So this is a very nice slide about prevalence of endocrine complication in India. You can see that the prevalence has increased drastically over last 10 years. The data, current data, has been compared to that of the 2014, and we can see that short stature, hypogonadism, hypothyroidism, hypoparathyroidism, diabetes mellitus, adrenal insufficiency, all of them has raised. So let's go through this one by one and get a practical approach. So the growth failure or the short stature in thalassemia patients, it is always a disproportionate one. Why? Because the iron, it gets deposited in the vertebra, leading to platyspondylosis. And hence, the torso or the trunk or the upper segment is shorter as compared to that of the lower segment. So the contributing factors differs over the age. In first 5 years, causes anemia, hypoxia, and mostly the nutritional deficiency. In next 5 years, because of repeated transfusion, the iron gets deposited into the growth hormone axis, that is GHRH, GH, and IGF-1 axis, leading to growth hormone deficiency and hence the short stature. And after 10 years, delayed puberty is the cause because iron gets deposited into the HPG axis, that is hypothalamic pituitary gonadal axis. So all of these axes are involved, leading to short stature. So what we can do here is we have to check height and weight 6 monthly. Easy, right? कोई test नहीं करना है, height check करना है every 6 monthly. That is the easiest thing we can do. And checking height and weight is just not checking height and weight, but we have to plot it on the growth chart. If the height is significantly less, we should always check for the bone age and evaluate for growth hormone deficiency. Now, short stature बाकी associated endocrinopathies के वजह से भी हो सकती है. So we have to rule out other endocrinopathies as well. Optimize transfusion and chelation. The serum ferritin should be less than 1000. Definitely it should be less than 1000. And we have to correct nutritional deficiency. and growth hormone therapy to be given only in proven patients with growth hormone deficiencies. This is a very beautiful slide. Here you can see that in first patient, the child is definitely short, below third centile, but at least this girl is following the curve, right? But in the other chart, the child is severely below third centile. And here we need to do an urgent growth hormone evaluation. She's a 14-year-old girl. Her epiphysis is about to get fused. We have very less time left, and hence urgent evaluation of growth hormone deficiency and treatment is very, very necessary. So coming to our next slide, hypogonadism, it ranks #1 and is the most common endocrine complication in patients with thalassemia. Spectrum can vary. There can be either normal onset of puberty, there can be either delayed onset of puberty. अगर दोनों नहीं है तो puberty शुरू हो गया है but it has stalled, it has stopped, or it can be complete failure of onset of puberty. So what should we do? We have to check LH, FSH, and estradiol. We have to see whether iron is deposited in the pituitary or in the gonads. So if LH and FSH is low and estradiol is also low, then we have hypogonadotropic hypogonadism. But if LH and FSH is raised and estradiol is low, then we have a direct gonadal damage because of iron deposition into ovary and testes directly. Very easy also. Here also we just have to check Tanner staging every 6 monthly, very, very necessary. Sometimes pelvic USG is needed in girls to look for ovarian uterine size. We treat these patients. In girls, we give ethinyl estradiol with a gradual increase in dose. While in boys, we give depot testosterone injection every 6 monthly. We reassess. If there is no response, then we have no other option left, but the full virilizing dose of testosterone has to be given. So this is very, very important because it is the most common endocrine complication we are facing in patients with thalassemia. Next, again, very important, if the iron gets deposited into the pancreas, what can happen? First, we all know that the beta cells of pancreas, it produces insulin, right? But this iron overload, it causes complete destruction of beta cell, giving us an overt insulin deficiency and diabetes mellitus. अगर बीटा सेल नॉर्मल है, इंसुलिन भी प्रोड्यूस कर रहा है, बट जिंक डेफिशिएंसी एंड क्रोनिक अनीमिया के वजह से देयर कैन बी इम्पेयर्ड इंसुलिन एक्शन. अगर ये भी नहीं है तो देयर कैन बी इंसुलिन रेजिस्टेंस बिकॉज ऑफ क्रोनिक हेपेटाइटिस बी एंड सी इन्फेक्शन. So in patients with thalassemia, there can be overt diabetes mellitus, that is type 1 diabetes, there can be type 2 diabetes, there can be impaired fasting glucose, impaired glucose tolerance, all of this can be present. So we have to be very, very aware. And one very important thing is that this diabetes, high sugars can also damage kidney and heart, which is already damaging patients with thalassemia. So it is going to make it worse, right? So what we have to do is annual fasting blood glucose level has to be checked from 10 years onwards. If fasting blood glucose level is deranged, then we have to do oral glucose tolerance test. Very, very important thing. Please do not do HbA1c in any patient with thalassemia. Because what is HbA1c? HbA1c is glycated hemoglobin. मतलब hemoglobin को कितने glucose molecules attached है. अगर hemoglobin ही कम है, it is a disorder of hemolysis. The HbA1c is not going to help us anyway. So please do not do HbA1c. We can use fructosamide as a test instead, but it is little costly. So in all the endocrine patients, for management of endocrine patient, I'm going to tell again and again that intensive chelation is the key. If patient has type 2 diabetes, dietary modification and exercise along with metformin can help us. But if there is overt diabetes mellitus, we have no other therapy than insulin therapy left with us. Yes, of course, there are some other drugs also, but they are under the trial. Now coming towards thyroid disorder, which is hypothyroidism. Now in hypothyroidism also, there can be three things. There can either be subclinical hypothyroidism, meaning TSH is raised, but T4 is normal. Then it can be overt hypothyroidism, that is primary hypothyroidism. मतलब iron has deposited into the thyroid gland, इसके वजह से thyroid काम नहीं कर रहा है. TSH is raised and T4 is very, very less. It can be central hypothyroidism, meaning the iron has deposited into the pituitary gland, इसके वजह से TSH is low normal and FT4 is also less. So इसका treatment क्या करना है? If it is subclinical hypothyroidism, we do not start thyroxine immediately unless and until the TSH is more than 10. We just have to intensify the chelation. But अगर ओवर्ट हाइपोथायरॉइडिज्म या सेंट्रल हाइपोथायरॉइडिज्म है तो हमारे पास कोई ऑप्शन नहीं है, वी हैव टू स्टार्ट थायरॉक्सिन एंड समटाइम्स इट इज ऑलवेज मे बी अ लाइफ लॉन्ग थेरेपी. Screening we have to do annually from 9 years of age. Thyroid profile has to be done. USG thyroid and antibody are less likely needed. And one very important thing, अगर iron deposit होता है pituitary gland में, so it is not going to affect thyroid alone. Like it is not going to affect thyrotrope alone. It will also affect somatotropes, that is growth hormone producing cells. It can also affect ACTH producing cells. Gonadotropes are also affected. So in any patient with any central pituitary hormonal deficiency, we should always evaluate other hormonal deficiency, other hormones produced from pituitary gland, especially before treating hypothyroidism. Why? Because in central hypothyroidism and associated ACTH deficiency, that is cortisol deficiency, if we give thyroxine without correcting hypocortisolism, the patient is going to land up into adrenal crisis. We all know that thyroxine increases the basal metabolic rate. And when there is increased basal metabolic rate, cortisol requirement is more. And we don't have cortisol if we are not treated. So it is going to be very dangerous. So coming to a less hypoparathyroidism, which is the prevalence is a little less. When we have to suspect, when calcium is low and phosphorus is high, we should always look for PTH levels. If PTH is inappropriately low or normal, then it is definitely hypoparathyroidism. Symptoms are just like that of the hypocalcemia, arrhythmias, paresthesias, muscle weakness, anxiety, all of these things. So here also we have to screen calcium and phosphorus 6 monthly after 9 years of age. Treatment is calcium and calcitriol. Now again, calcitriol, when the patient is on calcitriol, it does not absorb the calcium from the kidney. It is going to lead to nephrocalcinosis. Already our patient with thalassemia, as Preeti ma'am said, they already have tubulopathy. The calcium is losing. ऊपर से हम calcitriol भी दे रहे हैं. So there are high chances of patient having nephrocalcinosis. So we have to monitor 24-hour urinary calcium quarterly in those with thalassemia on calcitriol. Moving ahead, adrenal insufficiency. Now, adrenal insufficiency, clinical adrenal insufficiency is very less common in patients with thalassemia, but biochemically it is very common. So they may have symptoms like fatigue, anorexia, weight loss, hypotension, which are very similar to the patient with thalassemia, which may not even have the adrenal insufficiency. So when do we suspect? When we have unexplained hyponatremia and hypoglycemia in the patient. We have to check 8M cortisol annually after 9 years of age. This is very important. Again, why this is important? Because chronic adrenal insufficiency, agar thalassemia ke patient ko hai, and if he or she is undergoing by any stress, any infection, any stress, she is going to land up into adrenal crisis. Because during the times of stress, the cortisol levels are increased. Agar cortisol hai hi nahi, to kahan se badhega? So we have to always check what cortisol levels, treat it if there is cortisol deficiency, and prevent adrenal crisis. Sometimes doing 8M cortisol is not enough. It does not tell us whether there is cortisol deficiency or not. We sometimes do ACTH stimulation test to be confirmed. Treatment is Hyson tablet, which has to be given in 2 to 3 divided doses. And one more very important thing, agar thalassemia ka patient on Hyson hai, and he's undergoing through any stress, any infection, anything, we have to double or triple the baseline dose to prevent the adrenal crisis. So this adrenal insufficiency, adrenal crisis is very important. Sometimes it bangs our door without even knowing us. Now about bone health and mineral metabolism, Preeti ma'am has talked a lot about it. I'll just tell in short. Anything and everything in thalassemia can lead to bone health and mineral metabolism defects. Bone marrow expansion, iron overload, all the endocrinopathies, all the nutritional deficiencies, chronic liver disease, and iron chelators, all of them are going to affect the bone health. The symptoms are kyphosis, scoliosis, vertebral and other fragility fractures. So what do we have to do? We have to look for calcium profile annually. Along with it, we have to also check creatinine. Now, in any patient, whether it is thalassemia or non-thalassemia, we all know that after hysterectomy or after the patient gets after the menopause, any lady after getting menopause, we tell to take calcium and vitamin D, right? Why? Because these sex steroids are very much needed for bone accrual. तो इसीलिए if gonadal function is not good in patients with thalassemia, there is the bone mineral density is going to affect significantly. Hence, we also have to check for gonadal function in patients with thalassemia who have bone health defects. Sometimes DEXA scan is also needed for patients to look for bone mineral density. All the patients with thalassemia should take at least RDA of calcium and vitamin D. Timely pubertal induction, as I said, for bone accrual is very, very important. And in this patient who have severely deranged bone mineral density, we sometimes give bisphosphonate therapy as well. So this is all together, which we discussed from the last 4 slides or last 10-15 slides. If anyone wants, they can take the photo. Now this first thing, height, weight, growth velocity and SMR, that is Tanner staging. इसके लिए कोई पैसे नहीं लगते हैं. It is very easy and anyone and everyone can do, right? So this I think in every visit or at least every 6 monthly, this has to be checked and has to be plotted on the growth chart. Sometimes the screening is needed earlier, before 9 years also. Agar ferritin levels बहुत high hai, more than 2,500, and if there is poor chelation, and if the patient is symptomatic. Now coming towards the end of the slides. So hematopoietic stem cell transplantation and gene therapy. As Lisa ma'am said, it can cure the thalassemia, but mind it, it can never cure the endocrine surveillance. You can see here, this is the last 3 years ka data from Hong Kong. So 3 years post hematopoietic stem cell transplantation, they have seen and they have evaluated for endocrine disorders. And they have seen that gonadal dysfunction, growth failure, abnormal glucose metabolism, adrenal insufficiency and hypothyroidism were still there in all the patients with thalassemia who had underwent bone marrow transplantation. So why? Because there can be pre-existing iron overload and also gonadotoxic conditioning. The drugs we use for gonadotoxic conditioning like busulfan, cyclophosphamide, they can affect the gonad. It can lead to primary ovarian insufficiency in girls. In boys, it can lead to azoospermia and oligospermia and affect the growth and lead to growth hormone deficiency in both. So long-term endocrine follow-up is very, very important. And one very important thing is before conditioning, we should always ask the parents and tell them about the fertility preservation, what we can do in all these patients. So all these infertility clinics, all the gynecologists nowadays, they preserve the gamete, they do cryopreservation. So these patients with thalassemia, they can use those preserved gametes in future life whenever they are planning for pregnancy. This is very important. Now, we all know that prevention is the best medicine. Hence, optimal transfusion, adequate chelation, regular screening, and timely intervention is very, very necessary. And intensive chelation can definitely reverse early cardiac and endocrine damage if we have detected them early. So, some practical take-home messages. Every thalassemia child is an endocrine patient. Please do not forget this. Screen early, screen often. The endocrine window opens at 9 years of age. Start annual comprehensive screening. Hypogonadism ranks number 1. Assess Tanner staging every 6 monthly. Please do not wait for the complaints that patient aa raha hai aur bol raha hai ki doctor mujhe periods start nahi hue hai. We don't have to wait till that stage. Now, again, fasting blood glucose level has to be checked annually. Please, please, please don't waste money. Avoid doing HbA1c in all the patients with thalassemia. We can use fructosamine instead. In fact, there is no use of doing HbA1c or fructosamine. Fasting blood glucose level and sometimes OGTT is sufficient. We have to keep ferritin less than 1000 nanogram per ml for the best endocrine output. And yes, as I said, for bone marrow transplantation or gene therapy, it cures the blood, it cures the thalassemia, but not the endocrine damage. And hence the lifelong follow-up is very important. We should talk about fertility to all the patients, counsel early, and consider gamete preservation. Multidisciplinary care with all the pediatricians, hematologists, endocrinologists, and gynecologists is the gold standard treatment. Thank you very much.
Yeah.
Thank you so much, Dr. Bhakti Kataria, ma'am. It was such a wonderful.
Dr. Neelam Mohan madam is there. Please take a message and from her. No? Dr. Neelam Mohan madam is there.
Hello, we welcome Dr. Neelam Mohan ma'am, CIAP president, on behalf of Women Pediatrician Forum. Madam, we want words of blessing from you Hello, Neela ma'am, are you there?
I saw her, but I think she has left. Okay.
I
Yes, madam.
think
But
she is not there. She has left.
no, she is
I
there,
believe.
but she is unmute and she is there.
Acha, okay.
Any-
So,
Yes.
any questions?
Someone
there are
has
lots.
asked about
Excellent,
the
excellent
thalidomide
talk. I
process.
must say, why all of you, Bhakti, your talk superb, eye opener for all, and the key messages are so important. Everything, bilkul, gold standard. And most important, right, started with Dr. Preeti. Wonderful, nutritional, the small things, tidbits to be taken care of.
Thank
And
you, ma'am.
same is Liza Balsara. All you are doing excellent to improve the quality. Thank you so much, dears, all of you.
Thank you, ma'am.
Questions, dears?
There are not many questions in chat box. Only someone asked about pros and cons of thalidomide. Any of our faculty would like.
One question I asked in the group that Dr. Bhakti, you told it is in your this presentation. Will you please answer that question?
Yes. So one of the thalassemia parents has asked that why the iron overload, why does the pituitary gland is involved in patients with thalassemia? Because of the repeated blood transfusion, the iron which is there, it gets overloaded. And this increased iron gets deposited into the pituitary gland. Now, pituitary gland is a boss of all, right? It secretes many hormones. It secretes growth hormone, it secretes TSH, it secretes FSH and LH, which is required for onset of puberty. Along with that, it secretes cortisol also. All of these are secreted by pituitary gland. But if the iron gets deposited into the pituitary gland, it is going to cause deficiency of all of these hormones. And hence, because of iron overload and improper chelation, the patients with thalassemia can affect the pituitary gland. I hope I'm clear and audible.
Thank you,
One of
Dr.
my one of my senior thalasssemic angel, Dr. Komal Aher. She has done BAMS and she was with me since the age of 3 months. I request Dr. Komal Aher to just say a message to all the attendees over here. Ki with the willpower, we can just fight anything. So, Dr. Komal Aher, Dr. Komal Aher, can you hear me, beta? Dr.
I think
Komal?
she is there, just saw her name.
Yeah,
Rajiv Ahe.
yeah, Rajiv Aher is his papa, madam, her papa. Anyway, I think. Dr.
Hello,
Komal?
can you see?
Yeah.
Am I audible?
Yes.
Hello, everyone. This is Dr. Komal Aher. I have done my BAMS from Nasik only, and recently I have done my MBA from DY Patil in hospital administration. So currently I am working with a company which is related to cardiac cath labs, and I am on my way to also launch my clinic very soon in Nasik. My small message to everyone is that you just need to, I guess, face every challenge you have in front of you with the help of your parents and the blood donation donors and all the doctors. It is very much possible to live a normal life, and more power to all the parents and the patients who are living with the condition. And thank you so much, Loda ma'am, that you gave me the opportunity for talking here.
Thank you, beta. Bhakti, you stop sharing, screen sharing. She has been featured in International Thalassemics book also. Okay.
So, Dr. Alpana, where are you?
Let's take a screenshot of. Please, everyone, keep your videos on.
Yes.
एक मिनट, let me keep on all mode. It is yeah. Now, just a minute. Huh? Yeah.
And ma'am,
Okay, I had taken a screenshot.
So
Anybody
I'll
ask
go.
Anybody want to ask any question from the audience? Because many non-medicals also has joined who are parent of thalassemia or thalamic cancers, thalassemia cancer. Anybody?
Sangeeta, there is one parent, I think, Mr. N.R. Kadri, has been asking questions in the
Yes.
chat box. Just attend to him. No, his child, he doesn't know where to bring them.
Yeah. कादरी जी, यू कैन आस्क योर क्वेश्चन इवन इन हिंदी, इट विल डू, नो प्रॉब्लम. आप हिंदी में भी क्वेश्चन पूछ सकते हैं. और यदि कोई पेशेंट जो है यहाँ हमारे साथ में थैलेसीमिक का कोई बच्चा है जो हिंदी में कुछ क्वेश्चन पूछना चाहता है, तो हमारे यहाँ सब जितने भी जो यहाँ स्पीकर्स हैं, फैकल्टीज हैं, दे आर रेडी टू गिव द आंसर
Hello.
टू योर क्वेश्चन. या
Hello.
हाँ जी, कादरी जी
Yeah,
बोलिए.
madam. Yes, yes. First of all, thanks a lot. Your panel and everybody has given very means technical knowledge, but that was far away from our understanding. But still, it was good for our perspective also. The second thing, madam, my kid, that is 15-year-old daughter, is there. She is thalassemia, and the same everything was related to her. So I am very interested that I should go through such care, whatever you have given here. But our what we can say, we are not. It is not possible to us to reach Mumbai every day for every consultation like this. I am from Chhatrapati Sambhaji Nagar, Aurangabad, and here our doctors maybe they are knowing these things, but still we are not getting these suggestions from doctors. So we are just going through. We have one society here also. Mr. Anil Divekar is there. He is taking care of many things, but we are not getting all these things whatever you discussed just now. So now I am more concerned because my daughter is 15 years old. So first of all, thanks a lot. You have given very brilliant informations, and that is useful for us. But some are not easy to catch. That's all. This much only I want to say.
ओके, थैंक यू कादरी जी. और आप ना मेरा नंबर ले लीजिएगा. मैं ऑल ओवर इंडिया की ऑलमोस्ट 130 थैलेसीमिया एनजीओ से जुड़ी हुई हूँ और आपके हर क्वेश्चन का आंसर देने के लिए हम तत्पर हैं. आप कभी भी मुझसे पर्सनली कांटेक्ट कर सकते हैं. हमारे नासिक का थैलेसीमिया जो सोसाइटी है काफ़ी अच्छा काम कर रहा है. तो हम कोशिश करेंगे कि फ्यूचर में हमारे जितने भी जो थैलेसीमिया एक्सपर्ट्स हैं यहाँ पर जो आज हमारे फैकल्टीज आए हैं, उन्हें हम फिर से एक बार बुलाएंगे और आप सभी के प्रश्नों का समाधान करने की हम जरूर कोशिश करेंगे. तो वो
Thank you, madam.
हमारी
Thanks a
लैंग्वेज
lot.
भी तब हिंदी या मराठी में रखेंगे हम.
ओके मैडम. सो
या
आप चैट बॉक्स में नंबर दे दीजिए
जी
मैडम.
बिल्कुल
आपको
बिल्कुल.
थैंक्स.
यस यस.
और इन्होंने ये क्वेश्चन ये भी बोला था कि संभाजी नगर में इस तरह का एक टॉक रखा जाए. So शायद मिस्टर कादरी इज फ्रॉम संभाजी नगर, तो इट पॉसिबल सम टॉक्स इन द रीजनल लैंग्वेज कैन बी टेकन. मैंने अभी मैसेज में भी लिखा है कि इस तरह के कुछ हैंडआउट्स अपन बना सकते हैं और अगर लोगों को रीजनल लैंग्वेज में दे सकें तो बहुत अच्छा होगा, क्योंकि कहीं ना कहीं नॉलेज इंफॉर्मेशन हर समय बढ़ती रहती है. तो जैसा वो महसूस कर रहे हैं कि उनके पास इतनी इंफॉर्मेशन नहीं थी और उनको कुछ एक्स्ट्रा मिला, तो जहां तक भी अपना पर्पस तो इतना यही है सभी का कि किसी की भी लाइफ इंप्रूव हो. जैसा वो कह रहे हैं 16-year-old गर्ल है, तो आई थिंक उनकी हेल्प कर सकते हैं. वो कनेक्ट होंगे आपसे, बात करेंगे.
अनिल जी, आप कुछ मैसेज देना चाहेंगे?
ये नहीं, मुझे पूछना था ये जीन थेरेपी का क्या चांसेस है मतलब इंडिया में. मैं इसलिए पूछ रहा हूँ क्योंकि एक मिनट, मैं इसलिए पूछ रहा हूँ मैडम क्योंकि मेरी डॉटर यूएस में है. मैं 2 साल पहले यूएस में था और मैंने वहां पर काफी कोशिश की जीन थेरेपी से जानकारी लेने के लिए. न्यू जर्सी में काफी हॉस्पिटल्स में है, मुझे उतना नहीं मिला. लेकिन मैं कुछ पेरेंट्स से मिला वहां पर, कुछ डॉक्टर्स से मिला, तो एक पेरेंट का अभी जीन थेरेपी उसका कंप्लीट हो रहा है, मतलब हो गया है. आई थिंक फिलाडेल्फिया की कोई हॉस्पिटल में उसका हुआ है. और शी टोल्ड मी कि नेक्स्ट वीक में मैं आपसे डिटेल में बात करूंगी. शी इज नाउ बैक होम बट शी इज नॉट इन पोजिशन टू. तो हमारे यहाँ इसका क्या मतलब कितना उसका जो खर्चा मैंने पूछा कि व्हाट आर द एक्सपेंसेस, सो शी सेड के ऑलमोस्ट अराउंड 30 करोड़, इंडिया के हिसाब से 30 करोड़ तक उसका था, बट काफी काफी उसका जो कवर, वो इंश्योरेंस कवर था, तो उसको नहीं। बट हमारे यहाँ क्या चांसेस है, मतलब क्या फ्यूचर है इसका? क्योंकि काफी बच्चों का मैंने देखा, नेट पे भी मैंने देखा, काफी यूएस में काफी बच्चों का हो गया, मतलब अब्रॉड में काफी बच्चों का हो गया है।
Dr. Lisa,
Can I answer?
Lisa, are you there?
Yes, Dr. Preeti ma'am.
Yeah, so gene
You were
therapy is
talking
there.
about gene therapy and
हाँ प्रीति मैम,
Gene therapy is there.
Yeah.
Gene
और
therapy
anybody?
हो रहा है.
मैम थोड़ा सा
Any-
लाउडली मैम, आपका आवाज
अपनी
थोड़ा सा।
हाँ, कोई
ट्रायल्स
भी दे
अपनी
सकता
कंट्री
है।
में है जीन थेरेपी के. So can you hear me?
Yes.
हाँ 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 ठीक है.
Hello.
Yes, yes ma'am, yes
Yes.
ma'am.
So trial काफी हद तक आगे बढ़ चुके हैं हम भी जीन थेरेपी में. आई सी कि नेक्स्ट 5 साल में जीन थेरेपी विल बी अवेलेबल इन इंडिया. दैट इज व्हाट आई फील. जब भी मैं कॉन्फ्रेंसेस अटेंड करती हूँ तो काफी प्रोग्रेस हो रहा है अपनी कंट्री में. हम खुद की जीन थेरेपी लेके आने की ट्राई कर रहे हैं अपने साइंटिस्ट. सो नेक्स्ट 5 साल should be the target for us is what I feel.
मैम सॉरी, मैं
Cost-
इसमें इसलिए
cost-
इंटरेस्टेड हूँ, मैम मैं इसलिए इंटरेस्टेड हूँ क्योंकि मेरा बेटा अभी वो बीएमटी के बियॉन्ड चला गया है, ऑलमोस्ट 38 ईयर्स ओल्ड. तो लेकिन वहां पर काफी बड़े बच्चों का जीन थेरेपी वहां हो रहा है और उसके रिजल्ट भी अच्छे आ रहे हैं. तो देख रहे हैं कि अगर वो इंडिया में
जीन
भी हो
थेरेपी
जाए.
यूके में भी चल रहा है. सेंट मेरीज में अभी उन्होंने पब्लिश किया है उनका डेटा. जब मैं थी यूके में तभी वो जीन थेरेपी कर रहे थे बच्चों पे, मोर देन 12 इयर्स ओल्ड पे. उनका डेटा उन्होंने अभी पब्लिश किया हुआ है. सो जीन थेरेपी यूके में तो आ गया है, पर अपने साइंटिस्ट भी अपनी तरह से कोशिश कर रहे हैं जीन थेरेपी लेके आने को. सो मुझे लगता है कि और कॉस्ट भी काफी रीजनेबल हो जाएगा इंडियन पेशेंट्स के लिए, बिकॉज वो अपना सेल्फ डिजाइंड जीन थेरेपी रहेगा. तो 5 साल में आई कैन सी थिंग्स चेंजिंग इन द वर्क सिनेरियो. जीन थेरेपी विल बी इन.
अनिल भाई, मैं आपके क्वेश्चन का एक छोटा सा जवाब ऐसा देना चाहूंगी. लास्ट ईयर हमने जब ये वेबिनार ऐसा लिया था तो सैन जोसे में हमारे जबलपुर से किए हुए स्पेशल जीन थेरेपी एक्सपर्ट, उन्होंने बहुत ही अच्छा टॉक दिया था. एंड ही हैज डन मल्टीपल जीन थेरेपी ट्रीटमेंट इन यूएस. So he is in touch with me and I am also in touch with him. So I will definitely contact again ki what is the scenario right now and what is the cost scenario. So I think he will also answer our few questions. And even we can invite him for the webinar, in such webinar also. He will be very happy to join with us.
So we should be hopeful, मतलब जल्दी यार.
Yeah. I will share that link also. I'm having that recording of last year webinar, which we have taken on 8th May 2025. I will share that in the group. Okay. Now it's the time is quite over. I request Dr. Alpana Shukla to proceed for vote of thanks.
Thank you, Sangeeta ma'am. I take this opportunity to give the vote of thanks on behalf of Women Pediatricians Forum for this webinar on thalassemia. First of all, I would like to thank our excellent expert panel, Dr. Preeti Mehta ma'am, Dr. Lisa Bulsara ma'am, and Dr. Bhakti Kataria ma'am for your excellent inputs in the subject and giving us the recent updates on all the topics. Next, I would like to thank Dr. Neela Mohan ma'am, our President, Central IAP, who spared her time to join us. And of course, all the participants who have joined us and spared their long time to hear in this. And especially, I would like to thank the parents of thalassemic patients and the thalassemic angels also who have all come here. Thank you. Thank you very much.
Thank you so much. And I would just take an opportunity to congratulate the WPF team for the consistent efforts. And somebody was asking for the Shadi. The Transplant Coal India supports a lot. And they've completed almost 1,000 BMTs. Maybe not for your child, but for others. The transplant cost can go anywhere between 10 to 15. And Coal India does support it, depending upon it's an haplotype matching or the other. So there is a ray of hope. And thanks to the Women Forum to bring this all. And one more, I missed it, maybe I joined a little late, that don't forget, majority of the time in thalassemia patients, we are focusing only on the iron and hemosiderosis and its subsequent effect, whether it's on the liver and the heart, and you do your MRI to know all that stuff. But it is also important to know that despite all this, sometimes they can get the hepatitis C infection, though it has reduced a lot. But one of the largest series in India on hepatitis C and thalassemia I worked with. And now you have medicines which can be used for 3 to 6 months, depending on there is cirrhosis or not, and can prevent the liver from further getting damaged. So do remember that Hep C is treatable in thalassemia too. So that was one point I just wanted to add. Thank you so much.
Thank you very much, ma'am. Thank you very much.
Thank you very much for adding on your views, dear Neelam. Thank you, everyone.
Thank you, Madhuji. I really admire you and Sangeeta. I mean, I'm totally your fan. अगर किसी ने आपको फैन की लिस्ट में नाम डालना है तो मेरा जरूर डाल दे. And
Okay. Dr. Alpana, you can continue.
Thank you, everyone,
Thank you,
once
everyone.
again. And we can now stop our session and
Yes.
wait for the next one.
Thank you
Yes.
everyone for the patient listening and the time and
Thank
the
you all once
opportunity.
again for joining the
People are asking
webinar.
for the take-home messages as well as to share the PPTs. So I don't know how much who is agreeing or who is not. You can
No,
figure
madam,
it
they are
out.
not going to share the PPT because it is their
Yes,
property.
sure.
Definitely, I
But,
have taken few screenshot and that I will share in the group.
Okay,
Very
fine.
important few screenshot I have taken, and in
I know.
future we will take in a local language also. I think seeing the
ठीक है,
response
चलिए.
today from the
We'll
parents.
talk about making some handouts if you think so in the local
Yes.
language with the messages, all the crux of all the PPTs. Okay.
Yeah. Thank you all. Thank you all.
I just have one message.
Yeah,
I just
thank
have one
you.
message to give all the thalassemia children and parents कि आप चलते
Yes.
रहो और हम आपके साथ हैं. हम भी साथ में चलेंगे तो मंजिल तक पहुंच जाएंगे.
Yes, ma'am. Thank you so much. Thank you.
And I always say, कोई कार्य मनुष्य